Dear young colleagues, this is phaco surgery of a non-intumescent white cataract. Nuclear sclerosis is probably grade 3. By this time, main incision and one side port incision on the right side of the main incision has been made, and this is the patient is moving his eyes. We can see that the cotton tipped bud is supporting the eyeball to make the incisions to prevent subconjunctival hemorrhage. Now a big air bubble has been injected into the antechamber, and now trypan blue dye is sprayed over the anterior capsule of the lens, cataractus lens. The dye is washed out immediately afterwards within 3-4 seconds, and this is enough staining to make arexis. I have heard that some of my colleagues wait for 15 seconds. I think that is not necessary. Good staining occurs within 4 or 5 seconds, and it saves your surgery time. Now the anticapsule has been incised at the center with a 26 gauge bent cystitome, and there is no leakage from the lens, cataractus lens, through the puncture, and it indicates that this is a non-intumescent cataract. Capsulorhexis is then done using Utrata forceps. And now, since this is non-intumescent, a little bit of hydrodissection is done, though if we don't do hydrodissection, then also it can be done. Viscoelastic substance 2% SPMC has been injected, and now is the time to enter into the eye with the tip of the phaco handpiece. In this case, we are going to do direct chop. 1 sculpt, 2 sculpt, and engage the tip. I want to clean this cortical matter first and then go again in the groove. Hold it with vacuum. I am in phaco 2 mode. Vacuum is 450. Hold it with high vacuum firmly and then chop it. The machine being used is Oatly's Catarix 3 phaco machine. It's a nice machine with pneumatic cutter. Whenever PC rent occurs, you can manage the PC rent very efficiently. 1200 cuts, inbuilt air compressor, and no need of a gas cylinder. Now the fragments are being emulsified and taken out. Phaco power at this time is 60% and flow rate is 45 ml per minute, and as I have told earlier, vacuum is 450 millimeter of mercury. So the nucleus and epinucleus has been removed, and now the cortical matter is cleaned. I clean it with direct Simcoe cannula. This is a 23 gauge, very thin Simcoe cannula. I got it from Indo-German. This is cortical matter being cleaned, going through the side ports. This is the sub-incisional cortical matter. It's removed. That's it. The cortical matter is nicely removed. Capsule is polished. Viscoelastic substance is then injected into the antechamber, and now a hydrophobic acrylic intraocular lens is implanted. You can see that some black thread-like thing is there in the antechamber. I don't know how it went. Probably it was in the I don't know, somehow it has gone into the antechamber, and I am keeping an eye on it, and now I am going to bring it near this incision, and now I am going to depress the posterior capsule and it comes out. we have to look into the antechamber very carefully. There should not be any foreign material, any metal particle, anything lying on the iris or underneath the iris. Now viscoelastic substance is thoroughly washed. I go behind the IOL, flush BSS behind the IOL, between the space between the lens and the posterior capsule, and now again I flush with irrigating probe of the bimanual IA. Then I use the bimanual IA and give a nice wash, nice lavage of anterior chamber. In this way I prevent TAS in almost all of my cases. And TAS is the most disgusting thing. Little bit of moxifloxacin, 1 or 2 spots has been injected into the antechamber. Now the side ports are hydrated to make this waterproof wounds, and now the final wash is given. So this is moxi lavage. Moxifloxacin has been injected into the antechamber and it is being washed out. This is the final wash under higher magnification. When I go to higher magnification, my mind is working on the antechamber should be very clean. There should not be any cotton fiber, any metal particle, anything. Any foreign material should not be there in the antechamber. That's it. Now the antechamber is formed and the case gets over. Thank you very much for watching. Hope these videos are becoming useful in your practice.